Welcome friends once again to our NPTEL MOOC module on health economics. This is the course where you can take for your credit hours as well as per the IIT and most of the IIT Council mandate and rules and even the NEP, New Educational Policy Structure. MOOC courses are considered to be useful. So far I heard it is of 40% of the content is suggested to be included in your credit hours. Hence health economics has huge value. Health economics of this kind of person will be useful, and this is a 4 credit course as per the IIT equivalent structure. And now we are explaining on the issues of health system. In our previous lecture also we discussed economics of health system. Now we are discussing tax and social health insurance mechanism as part of the health system. Here are our objectives to accomplish the directions towards understanding the health system. We are now covering theory and the evidences for different options of financing a healthcare system. And second objective here is to discuss about the inherent strength and weaknesses of the tax and social health insurance mechanism. And third is on the acceptability and transparency, stability and cost control aspect of addressing health systems. Yes, it is very lengthy. We may divide this last objective to a next lecture. We will discuss if it is perfectly fine to accomplish within this time. It's perfect, it's good, else we will be extending to another lecture. Let us understand, as I iterated several times, that it is not just reading healthcare system in isolation. Rather, you should also prepare a healthcare system through different context in our every week. Now, this week is purely confining the issues around health system, and you are suggested to also prepare number of questions. We will add relevant questions. It's almost 50% or even more than 50% questions will be directly from the slides, and some questions will be from outside the slides, but relevant to the context which is being explained. So, the first aspect is in order to have a better healthcare system, we should understand the financing structure of it. There are actually several ways to finance medical care. The important aspect where the large burden is on the patients or the individual is through their private or their out of pocket spending. This is usually directly paid for the healthcare. And second type of finance is through voluntary health insurance schemes that usually paid through premiums that may be partially or fully financed. And the VHI, voluntary health insurance premiums, is again through private health premiums. Third one is also counted in developing countries context, where role of government and the regulations really matters, since market does not function efficiently. Since we already discussed in the last lecture about imperfectly competitive structure and the market failure, that has led to the intervention of public policies. So, policymakers influence is very essential. Otherwise, the insurance market may not function very well. Eventually that may spoil the entire health system. Hence, the third category is relevant is none other than public sources. That includes again how public manages this financing. It is through either taxation or through social health insurance. To pay the healthcare services, in this case government pool the taxes, okay, or through social, where income, the certain proportionate of the income is actually contributed for the healthcare. So, we will be discussing different models as used in different countries setup. We will also cite the important literature which has covered these aspects, and we may also derive the context for Indian scenario, how Indian health system is functioning, how effective it is, and how far it is performing. Hence, the controlling the funding mechanism is for the policymakers, and that influence the funding, and also this helps in allocation of resources within the health system. So, control mechanism is essential, as I already mentioned. There is a scope to determine how much money should go into health and how that money should be distributed to match up the designated priorities. So, it is not just the healthcare per se, it should be by priorities, since our supply and demand framework in healthcare does not match, it does not give the right allocation that may lead to some kind of disturbances in the healthcare functioning or healthcare system. Hence, designated priorities has to be identified. When healthcare is actually funded from out of pocket payments, usually that is purely private and directly to the healthcare institutions. In that case, market really matters. If market is functioning well, OP considered to be quite rational. Since market is not guaranteed and its functioning is very difficult to evaluate and may not give a win-win situation every time, government has to enter. But in this context, OP payment case, government has no direct control over the resources. As I already mentioned that it is not just the healthcare that matters, it should be based on need of the patients, of the individuals. So, the priorities or the designated priorities and hence allocating resources are important. We have to discuss the sharing of the burden of payments of healthcare fairly across the population, how the sharing is made, who really bears the burden. Even if it is taxes, is it too easy? Even if it is the allocation through or the pooling through income, certain proportion of income, that income is not just directly imposed on the employer or the employee, that might be some sharing. Achieving appropriate levels of preventive health measures also, and this need based will also deal with important other objective as well. So, the resources for financing is broadly divided into direct taxes, indirect taxes, health insurance premiums or direct payment, and other mechanisms. And individuals are the ultimate sources of funding for healthcare. There are typical important features of healthcare system. First aspect is universalization of insurance, if it is made through insurance. In that case, universalization, when I say it is possible, it has been observed that it is the government or the single payer who has actually made the services universal. It is not differentiating accesses. The government provides insurance coverage to all the residents automatically. The cost of this insurance is covered by taxes rather than premiums. Thus, there are no enrollment fees. Okay. Whereas, in free care, another feature of the better healthcare system, even the healthcare system usually we address in this case is our public healthcare system has these features. Another is free care, where no cost is required. The cost of medical care is either free or extremely inexpensive at government clinics and hospitals. Any premiums or deductibles or co-insurance are not the responsibility of the patient. Third one is actually provisioning, public provisioning healthcare or public healthcare provisions, where it is public manages instead of making it completely free or pan India level through universal insurance schemes. Like the last one we said is public manages the hospitals or clinics. So, then we have to understand health insurance, how it is actually funded, and usually three categories are there. The most important aspect is tax and tax based health insurance, then social health insurance and private health insurance. Here we will compare tax health insurance and social health insurance as they inherited several characteristics, but divergence between these are also important to discuss. How these concepts are different, how far this is creating load to the society, and who is bearing the burden, etc., we will be discussing, and whether the burden is leading to some kind of disturbances, whether that disturbances is stable or disturbances is actually creating further disturbances. We will be covering that aspect as well. Let us unfold the discussion of tax based insurance. Now, the simple source of this is called tax. So, this is considered to be a direct source of revenue, okay, and especially when we are counting income tax. There are indirect taxes as well through consumption taxes, or other government revenue such as licenses. These included direct revenues like income tax, indirect tax revenues, indirect taxes are there as well, okay, and licenses which I have already mentioned. These resources are pooled by government and allocated across all the demands on government resources such as health, education, defense through normal budget allocation process. A simple example, some of the countries are following like UK. UK has the National Health Service Scheme that is called NHS, that is largely tax funded. The residents are free at the final receiving end for the health care, and funding primarily comes through general taxation. And such models are even prescribed. We will also refer in UK's context, and Beveridge model is most cited. Thus, is also called nationalized healthcare system, nationalized healthcare scheme. This is actually Beveridge model named after William Beveridge, a British economist. The establishment of the NHS, that is National Health Service, in UK, United Kingdom, after World War II, and this is, as I told you, is primarily through the general taxation. The principles of this universal access, this is model actually emphasizes the principles of universal access in healthcare services. And the priority of this model is eliminating price rationing of the healthcare. Now, price rationing has its limitations. It creates non-accesses and mostly create inequalities in the society, because persons who are not or at the lower income quintile may not able to afford. So, now another type of financing is called social health insurance, that makes the health system robust. It is, in simple terms, social health insurance is paid by the employees and by employers, and then levied on their payrolls. Okay, it is paid on various ways, such as by the government or for the benefit of the unemployed, the retired, and other non-working dependents. On behalf of the persons who are covered by the program, the social health insurance funds pays care providers. There are some examples I have also cited for your reference. Here it is, Japan is mostly discussed in the context of social health insurance, and they have a scheme called NHI, National Health Insurance Scheme. This covers all residents, and the contributions are from the income. The government provides subsidies also to the low income individuals, since they are paying capacity or the contribution capacity is low. So, Japanese model is usually cited. In the social insurance schemes are actually derived largely from the Bismarck model, that is also called Bismarck's social insurance model. This is named after Otto von Bismarck, the chancellors of Germany. Okay, and introduced the, Bismarck introduced the concept of social health insurance in the late 19th century. So it is even before than that of the previous insurance model we discussed. Health insurance is provided through social health insurance systems, that is in short called SHI in different literature. So there are actually mandatory contribution from the employees as well as employers to address for the society and to make a better health systems. Multiple competing health insurance funds or sickness funds are also important examples of this aspect. Now, Bismarck health system shares the defining traits of the model, especially for the universal insurance, community rating, regulated private providers. The set of policies that comprise the Bismarck model reflect two major values. They are called solidarity and economic liberty. Since we emphasize on social framework, so here the first one is a strong solidarity is expected in this scheme, and that defines the health system a robust one. Similarly, it has also strong economic liberty as against the tax based scheme. The choice between Bismarck model and Beveridge model often reflects a country's historical development, their values and policy priorities. Many countries adopt hybrid models also, mix up on these models and incorporate elements of both approaches to strike a balance between equitable access and efficient resource allocation. So, you can refer the paper for further clarity on solidarity and economic liberty so far as social insurance policy is concerned. We will also discuss some of these details in our insurance chapter. I think if you remember very well, we have at this moment we are discussing economics of health system, and we have had a unit called financing and insurance in healthcare. In that unit, we have complete coverage on uncertainty and health insurance, etc. We also discuss about adverse selection, moral hazard issues, and also to some extent emphasize how far it is strengthening our health system. Now, let us assess the tax based versus social health insurance. Which one is relatively better? What are the strength and weakness of both the system based on the criteria? The criteria are we have considered 5, that is acceptability, transparency, stability, then cost control, administrative cost, equity and incentive structures. In all those 5 directions, we will try to evaluate. And another one important aspect also in 6 most important category is also referred to understand their implications of these 2 for the country. Implication may be checked through whether it is sustainable or not, this funding are going to be sustainable or not, whether it has better accountability and efficiency. So, we will discuss these criteria one by one. Then here it is acceptability and transparency. So, first aspect of this is that the structure we adopt or follow should be acceptable and transparent, and in that context there should be more or greater willingness to pay aspects must have been dealt, greater willingness to pay for higher social insurance payments due to increased value placed on transparency in collecting and utilizing money. So, social insurance payment has higher degree of willingness to pay because of its transparency and the utilization of that money to the people. So, due to the transparency, social health insurance strengthens patients' rights as consumers of healthcare with potential influence on the quality and accountability of health services. Tax finance transfers and grants are frequently used to supplement or bail out social insurance coffers. Second point is called stability. The stability of the taxes is influenced by the type of structure we are following, tax structure we are following. The income taxes are in fact more stable than the taxes that are imposed on more discretionary sources of revenue such as stamp duties, etc. So, first aspect of stability is to income. Then social insurance contributions are levied on incomes and are relatively stable source of revenue, and this is indeed balanced against the fact that the financing base is narrower than with overall tax revenue. But though it is narrower, but actually it is balanced, the social insurance scheme. There are some examples in different papers, especially we are citing Workstop 2009 work, examined system-wide impacts of shifting between social insurance and tax finance systems. So, which system to be adopted, what kind of shifting is given is examined actually by this author. The author finds that switch to social insurance leads to a reduction in the formal sector's share of employment, which may in turn lead to fall in the level of employment. That is one of the important finding. The when we are saying the social health insurance scheme is actually largely dependent on the income of the employees. So, that may negatively influence the employees, and the extent of employment is already derived by the author actually has been negative. Hence, that is sometimes considered to be questionable. Given the concentration of social health insurance on payroll contributions, there are concerns that social health insurance has a negative impact on employment. This is what is mentioned. You may prepare for your exam. This may be given a sentence for justification, or maybe we may discuss MCQ based questions to differentiate the negative implications which has higher value, tax or social health insurance. So, the development of formal system of healthcare finance in the 19th and 20th century centered mainly on employment and workplace. There are several reasons. First, it is financial interest of the employers to have a healthy workforce with low absence of for sickness, so that the employer sponsored health service may be a rational profit maximizing strategy. Second, there are advantages of risk management to large numbers in health plan. The large number employed in provided better medical insurance, and that is considered to be efficient and with low transaction cost. In a competitive market, the share of effectively paid by the employer depends on the elasticity of labor supply. So, elasticity of labor supply really matters. Now, we will clarify what is this elasticity and how far this defines the stability, which we have already discussed. Now, yes, so to some extent in our insurance chapter, we will be covering type of insurance and the role of market, selection, choice of the individual, etc. But we are not emphasizing, we had not emphasized in that chapter on what is called stability. At this moment, we are trying to emphasize the issues of stability through the elasticity of labor supply function. Now, imagine two contexts. One is the stability in terms of what? In terms of employment, and or in terms of receiving the contract, receiving the wage rate. In what case the impact is more? Who is bearing the burden? Like if in the social health insurance structure, we know that it is nowadays, even in many countries, it is mandatory to have social insurance schemes. It is both employer and employee both will be paying. Now, who is actually bearing the burden? Okay, a larger burden of this cost. Of course, this is considered to be a cost. In a typical demand and supply diagram, if I just draw it here, you will see that I am just doing a rough work. So, demand and supply and demand, we usually take quantity and price over here. Okay. So, the owner who is providing has its supply curve, there are responses of supply at different price levels and demand for the product by the consumers. But in the labor market context, it is considered to be little different, since labor market is derived demand. And hence, if I just start with a rough work, demand curve and supply curve, now supply of labor and demand, as I already told you, it is based on the marginal valuation, okay, and this is also DL. Now, who is demanding labor? It is in fact the production unit, okay, who are demanding. Now, we are no more referring to quantity, it is actually the number of employment. Here, the rate at which employment is decided is due to wage rate. Okay. Again, there are lots of arguments related to rigidness of the wage rate, whether it is nominal or real. We are not going into that debate, not going to capture the issues of rigidity in labor market, etc. We are only simply trying to understand the implications of this cost sharing, implications of this social cost, social insurance cost, whether it is more on the laborer. Now, the supply side is actually determined by the laborer, okay. Hence, the impact will be observed differently. Like if I just say few words in terms of consumer surplus and producer surplus differently for this point and this point, we know that this portion is actually the consumer surplus and producer surplus, total surplus. In this case, it is also the total surplus. Okay. Now, at the starting point, if I just mark it here, this side is for the producers, this side is for the consumers, so far as typical demand and supply function is concerned. Okay. But in labor market, we will find just the difference. Labor market, this side is for the laborers, okay, and this side is for the producers, or they are at this moment the employers. Okay. Now, in this context, we have the diagram and we will try to clarify further. Now, here is the diagram. I will also show you the detailed diagram in next one. Now, do not you think that the implication of the cost, social cost insurance will be different based on the bargaining power of the either demander or the supplier. So, the bargaining power lies with the demander or the suppliers. Let us see which curve is going to be shifted. As in the typical demand and supply curve, we have seen that supply curve due to taxes, etc., supply curve used to be shifted backward. Okay. But in this case, we are actually just counting the derived demand function, and hence the approach will be little different. And the demand curve here is the labor demand curve by the producers, which is in fact hard hit due to the bearing the cost of social insurance. Whereas the supply curve of the labor is largely shifted backward or rightward, depending upon either we have a outrightly different health system is improved hugely, so that supply of labor or the population increased, or we have new registration system, or we are comparing a huge two different time period where our supply function, supply of labor is expected to be different. Whereas the demand for labor is a function of its marginal productivity, okay, and demand is again also dependent on or its shifts are also dependent on often certain external factors. See, if the cost on the company is very high, nowadays corporates are giving salary to cost to company, CTC salary. In the CTC salary cases, usually we see that they are including all kind of cost, okay, as part of their salary to their employees. So, when the CTC component increase due to this social insurance scheme, it is quite obvious that there will be backward implications of the demand curve. So, the demand curve we started is like this DL, okay, or DL here, okay. Now, there will be a backward shift, alright, and the supply we are not going to the natural supply curve, we are not going to disturb, and why it should start from this point? Because of the reservation wage rate, okay. You can read it through any macroeconomic chapter. So, if due to social insurance scheme, we will find that there will be some backward shift, alright, of the demand curve. The vertical gap, this gap is actually called cost of social insurance, cost of social insurance, isn't it? Now, we can easily plot 2 points, this is one, then this is another one. I am just marking it to identify the difference. In one case, we have taken a demand curve which is fairly elastic, another case we can take fairly inelastic demand curve, okay, and accordingly we will find a shift, and accordingly we will check supply curve and so. Now, I am just giving you a background at this moment. When the the demand for labor is different, and we will start with this supply curve, supply based on the supply function we will first evaluate, then we will also evaluate based on the demand curve as well, okay. At this moment we are shifting the demand curve based on the cost to social insurance, but if supply curve is same, then evaluation will be different based on the demand curve. If the supply curve itself is different, okay, the supply curve is elastic or inelastic, then nature of here we are presenting everything, okay. In one case you can see elastic supply curve, another is inelastic labor supply curve. Now, this is what I was trying to say, but at this moment I have mentioned simply the same diagram, the same supply curve. But to simplify you further, I was just trying to do the implications how deadweight loss etc. is calculated. Now, you can see due to this change, due to the new shift, we will have a new equilibrium point, okay. There is a backward movement, and the employment actually rate reduced to this level, there will be net change. This change you can mark, okay, through the deadweight loss. We will also present in the next diagram correctly. Now, in this diagram, the cost to insurance which I have already said is mentioned. This vertical gap is actually the cost of insurance. First one is called first block of the diagram. First one is called elastic labor supply curve. Another is called inelastic supply curve. Okay, so therefore this is relatively flatter. The first one is relatively flatter and the relatively steeper. Now, when the supply curve is elastic, that means with every incremental change in wage rate, there will be more supply, relatively more supply. So, bargaining power is more with the laborers. Okay. Whenever the cost of company is actually cost to the company through the insurance is more loaded on the buyers, the supplier of labor. In this case, we have already seen in the previous one that due to this shift, the new MPL, marginal productive labor, is here, and thereby we have seen that the wage rate is declined. Now, when the wage rate is declined, our supply curve is fairly elastic. That means the bargaining power is more with the laborers. Hence, the load will be less on the cost to the company. In this case, will be less on the cost of insurance will be less on the laborers. Okay, you can see the vertical gap. I can easily clarify. First one this whole area, I am just marking it, this whole entire area is actually the consumer surplus before any kind of distortion or changes or insurance scheme. Now, this area is in fact the consumer surplus, new consumer surplus. You can easily mark the total change in the consumer surplus. That is a loss of consumer surplus is this trapezium area. Okay. Now, out of that, what is in fact the loss due to the distortion in the labor market is in fact due to this loss. So, that means this one is relevant for us for discussion. Okay. So, this one we know that the wage rate has been declined and this portion is used to be the, this portion is used to be the the surplus with the laborers. Now, they have been hard hit by this area. The vertical distance is marked here, whereas the upper portion are actually, this portion is with the employer. So, now this vertical distance is there. Now, you can easily see, given the labor supply curve which is fairly elastic, we see the gap of the cost of insurance to the employer is higher than that of the cost to the worker. The reverse is true and it is marked here. You can see more load is when the supply elasticity of labor supply is fairly inelastic. The cost of the social insurance scheme on the worker is higher than that of this one, okay, than that of the employer. In both the cases, we have seen that the employment level actually declined. And the third one we will also discuss when there will be shift of labor supply as well. Okay. All those details we have identified and mentioned in our analysis, you can follow and clarify. And please note that in both scenarios, the simplifying assumption is made that provision of insurance does not affect the supply of labor, which we have already said supply of labor we have not mentioned. Now, in the next one, we will also actually discuss what will happen to the when supply of labor also changed. Now, you can see when the supply of labor is actually changed, not just cost to the company, this is what, this was already there, we discussed in our previous two model. Now, we are discussing when supply of labor is also changed, maybe due to better healthcare system, okay, what really happens. Even in this case, we will identify that employment level also badly hit. Yes, the extent of employment is the fall in employment is lesser as compared to other two, but the load again dependent on the elasticity of demand and supply. So, the bottom line in all these three model is that when the elasticity is higher, contribution of the worker actually reduced, whereas the contribution of the employer increased. Okay. When the elasticity is actually elasticity of demand or the demand for labor actually is lesser, that means the contribution of worker is higher and contribution of employer declines. And in this model particularly, when elasticity of supply also increases with a better healthcare system, when your healthcare system is robust and you have hardly disease rate is less and your mortality rate is very less, so your population might actually increase so that you can add more labor supply. So, in this case we seen that the labor supply function really matters. So, the contribution of the workers actually increases. Since now in our earlier case we have seen that the load on the worker are less, but now what happens the bargaining power will be more on the employer. Okay, why? Because they are getting at different contract level they are getting more labor supply because of higher labor supply function. So, the contribution of worker increases and the contribution of employer falls. Again it is also dependent upon the comparative elastic demand of both these two. So, in the next class I think it is we have already crossed the time. Next class we will discuss, we will continue this health system. We have discussed stability as a important direction of the social health insurance schemes. In the next class we will discuss about cost control. Okay, we will also share you the exact readings etc. So, I am just closing here. I am expecting your presence in the next lecture. Thank you.